Thank you for inviting me on this stimulating topic. These are my disclosures. So I'm mainly a clinician, and when the integrase inhibitors were made available, we got impressed by at least three major properties. Just the first of the three was the ability to overcome prior resistance in an unprecedented manner as compared to prior categories. The second point was the fastest viral fall ever recorded. We got impressed by, how speedy was the viral fall in those treated with integrase inhibitors. And the third item was that in spite of all clinical trials in treatment-naive patients have been designed according to a non-inferiority profile. I mean, with integrase inhibitors, we have actually seen a series of consecutive results of superiority when compared with older category. So what I mean is just to remind to those who are younger than me how the things were more than 10 years ago without integrase inhibitors in patients with multiple prior failures. The best we could get was below 400 copies with enfuvirtide versus what OB was optimized background. So the best you have, excluding the experimental drug. A bit better in case of power was the last PI developed was the darunavir, 46% below 50 and 22% with tipranavir. So when we got the first integrase inhibitor, raltegravir, and when we had more than two active drugs, what we were able to get, efficacy rate as high as 89% in patients with multiple resistance. But what was noticeable that even in patients with no active drugs other than the experimental one, we were able to get efficacy rates as high as 60%. That time was around 2008. For the first time, we established that we should pretend to get below 50 copies, even in patients with a heavy background of prior virological failure. The fastest viral fall ever recorded, just a picture to see that this is very, very peculiar. This is dolutegravir versus efavirenz, but more or less the same shape of picture can be seen with raltegravir. So there is an anticipated viral clearance with the integrase inhibitors. Someone might say, okay, but at weeks in between 16 and 24, both drugs are more or less the same. Yes, but from a pharmacodynamic viewpoint, such an anticipation is clearly interesting and fruitful from a therapeutic viewpoint. We will come on this later on. And you see, this is more or less the properties in terms of magnitude, 2 logs in 10 days in monotherapy with all integrase inhibitors. And if we compare with all drugs like Calitra, as an example, this was the trial published by Bob Murphy in 2001, AB378. I mean, a drug that saved dozens of thousands of lives. But the viral fall, as we can extrapolate from that graph, is much less spectacular as the one seen with integrase inhibitors. And the multiple superiority of integrase inhibitor, if you take, all the trial series, this is a simplified picture, including also the non-inferiority shown by bictegravir versus dolutegravir. You see with the stars, there's an unprecedented series of superiority shown in treatment-naive trial, in switch studies by integrase inhibitors, in spite of all these studies were designed as non-inferiority. So let's now look at some basic pharmacological properties that might be of clinical interest concerning integrase inhibitors. Looking at absorption, we see here raltegravir, the old and the new formulation, elvitegravir with cobicistat, dolutegravir, and bictegravir. There's some, just to note that in case of dolutegravir, there is a significant increase in absorption in case of a high-fat meal. So whenever we perceive to need a higher concentration in case of the presence of some mutation associated to integrase inhibitor resistance, even to taking the pill with the high-fat meal is an option. There's some discrepancy here you might note between the old and the newer formulation of raltegravir. We should emphasize that the new formulation has a much lower interpatient variability, so this might be attributable to this property. We all know that the one of the few important drug interaction of this category is the one related to the polyvalent cations, I mean, including laxative and antacid. And this is more or less the picture we might get with dolutegravir plus antacid. But if we skip one of the two drugs to hour later or 6 hours before, more or less with the PK profile tends to be the same as with the integrase inhibitor alone. This one is related to the half-life. I mean, we see here raltegravir has the shortest half-life. That's why the old formulation, the indication was BID administration, also the lowest protein binding. What is interesting in case of dolutegravir, in case of renal failure with creatinine clearance lower than 30 milliliter per minute, there is an unexpected and unexplained so far decrease in pharmacokinetic exposure. However, this is a healthy volunteer study. Healthy, no, I wouldn't say. HIV negative study in patient with renal failure, but just 8 subjects were studied. No specific data about bictegravir, but the drug is not recommended in case of creatinine clearance below 30 ml. We should also note that integrase inhibitors have never been studied in persons with advanced liver disease as classified by the Child-Pugh score, the C stage. So in extreme liver disease, integrase inhibitors should not be administered. Let's look at, this is much more interesting because there are some differences across the integrase inhibitors in terms of metabolism. We know that raltegravir is a pure UGT1A1 substrate, and there seems not to be any participation by CYP3A4 in its metabolism, and no specific position of substrate or inhibitors concerning transporters are known for raltegravir, while dolutegravir is at the same time substrate of UGT1A1 and other isoforms as well, and CYP3A4 is substrate of PGP, BCRP, and an inhibitor of OCT2, as we also heard from Andrea Calcagno before. Elvitegravir is the more dependent on CYP3A4 metabolism, but is also an inducer of CYP2C9, and BCRP is an inhibitor and substrate of ORTP1B3 and the substrate of ORTP1B1. Bictegravir is rather similar to dolutegravir, is an inhibitor of MAT1, is a substrate of CYP3A4 and UGT, and as dolutegravir has the common position of being an OCT2 inhibitor. Concerning OCT, what has been quoted and mentioned many times is the possible interaction, the documented interaction with metformin and dolutegravir. However, you see there is a measurable increase in metformin exposure. However, this is less than a problem in clinic. Some physicians keep the same doses of metformin. Someone use a 50% doses of metformin, but apparently there is no significant difference. You know, it's not insulin. We don't see hypoglycemia as with insulin. So the mechanism of action is different as compared to insulin. The same applies to bictegravir, which is also an OCT2 inhibitor. However, the magnitude of interaction seems to be lower. I wouldn't say this is a dangerous interaction, but is probably one of the few we could talk about when concerning integrase inhibitors, because you see here I found an old report that the exposure of metformin was possibly associated with a life-threatening condition is much, much, much higher than the one recorded in case of co-administration with integrase inhibitors. Another interesting point is what is the influence of being or not being also a substrate of CYP3A4. You see here with UGT101 only, the influence of rifampin on the exposure of dolutegravir is of lesser magnitude as compared to pure CYP3A4 substrate. We all know that all drug-drug interactions of which UGT1 is responsible are of much lesser magnitude as compared to those attributable to interaction with CYP3A4. When we have both UGT101 and CYP3A4 in the metabolism, as it is the case of dolutegravir, you see the influence is a bit greater as compared to dolutegravir. However, the double daily dosage of 50 milligram more than compensate for such interaction. While in case of bictegravir, the difference is much higher, suggesting that possibly bictegravir is more a CYP3A4 substrate as compared to dolutegravir, and the drug is not recommended with co-administration with rifampicin in spite of a study with a double bictegravir dosage. What about rifabutin? Not too much to say about dolutegravir, the negligible differences, and something more interesting on the side of elritercept, but especially for the increased concentration of desacetyl rifabutin, which is the active moiety of rifabutin. You see very worrisome increases in exposure that might be associated with optic neuritis and other central nervous system disorders. And dolutegravir plus rifabutin, more or less, nothing happens. You see, this is not a semilog scale, so more or less concentration are quite similar. While big plus rifabutin, there is a measurable decrease in bictegravir exposure, but there are no clinical data. There's the possibility of PGP induction by rifabutin, since bictegravir is only available as a single tablet regimen with emtricitabine and tenofovir. So there might be a decrease in tenofovir exposure. Concerning the some possible differences in terms of drug-drug interactions across the different integrase inhibitors. This is something we came across in Torino, a couple of patients with a much lower than expected exposure of dolutegravir in case of co-administration with valproate. So we looked back at our entire case series, and we found actually that those taking dolutegravir plus valproate had actually all a much lower PK exposure as compared to the rest of the case series at that time taking dolutegravir but not valproate. We looked at the Liverpool website, and we found that more or less there were no clinical data, but by reasonable inferences, no specific drug-drug interaction between dolutegravir and valproate or dolutegravir and valproate were predicted. We found some experimental work in rats showing that in these animal models, valproate might actually induce CYP3A4, and this might explain to some extent, might possibly explain some faster clearance of dolutegravir in these patients. One of the updated by the Liverpool sites suggested that possible some excipients, some magnesium contained in the valproate medication might also decrease the absorption of dolutegravir. However, dolutegravir, which is also very sensitive to polyvalent cations, had no PK differences when co-administered with valproate. So this happens, when physicians have some doubts, go on the Liverpool website and ask for, drug A plus drug B, what happens if there are no clinical data? And sometimes when clinical data come, maybe in accordance or maybe may introduce new interpretation what was inferred before. As an example, if on April the 7th, my football team Fiorentina won in Roma 2-0 3 days afterwards, Roma won 3-0 against Barcelona. So my question was, what about Fiorentina and Barcelona? So, and if we ask David Beck, okay, so what's going to be the outcome? So we click Fiorentina, we click Barcelona, you get potential interaction, and David says, no data available. However, based on results of recent matches between Roma and Fiorentina and Roma and Barcelona, the final score should be Fiorentina 5, Barcelona 0. So, you know, we should be cautious sometimes when we have no clinical data in interpreting what has been inferred, you know, sometimes. So, however. So, what about integrase inhibitor clinical pharmacodynamics? Before the advent of integrase inhibitors, those clinicians working a bit in clinical pharmacology were used to attribute the property of forgiveness mainly to the magnitude of the elimination half-life of the drug. This could be, you know, a classical example of the old Calitra and efavirenz. Calitra has a half-life of 5 to 6 hours, efavirenz 45 hours. If we stop taking the medication, with the coverage, residual coverage with Calitra is much shorter than the one we have with efavirenz. This is an historical notion for us. And if we look at, now this is the way we interpret why not 100% of patients achieve the virological suppression in spite of having very good drugs. We know that some patients do not take drugs while other patients have a suboptimal adherence. And on the chance of being suppressed or not, while being not completely adherent, forgiveness is one of the properties that actually contributes to this outcome. So if you look at a series of old clinical trials, there is a tendency to do better for drugs having a longer half-life, not surprisingly. So this is what we call the T2 related forgiveness. However, this is, if you look as an example, the Artemis trial, Calitra versus lopinavir versus darunavir. Darunavir did better, but did better only in those who were suboptimally adherent, and darunavir has a much longer half-life as compared to Calitra. This was our interpretation. However, with the first trials, this is a start mark in treatment-naive patients with integrase inhibitors, and afterwards, also with elvitegravir, especially dolutegravir, this sort of, you know, discrepancy versus standard of care drugs of the prior generation was repeatedly confirmed. We see here that in spite of having a much shorter half-life, dolutegravir was found to be superior than efavirenz. The same applied afterwards. Well, why that? The main reason probably is better tolerability leading to better adherence. This is easy to say. However, there is also a greater absolute intrinsic potency, a much higher inhibitory quotient if you stop taking the drug, but you know that your inhibitory quotient, in spite of having a shorter half-life, is so strong, so high that you keep on, you know, inhibiting the viral growth for a longer than expected time. We might have a longer residency time on target, which is also an interesting property. And also some contribution might also come for the faster viral load reduction, especially in the very first periods. If you interrupt at any time in the first, I would say, 24 weeks, in case of integrase inhibitors, the restarting point for growth for viruses is much lower in case of integrase inhibitors. But let's have a look. I mean, in terms of potencies, what we learned on a clinical ground that when atazanavir or efavirenz were used as third drugs, the nature of the NRTI background did matter, actually. I mean, those associated to Truvada did actually significantly better than Kivexa for a variety of reasons, possibly. This is a huge trial. Around 2,000 patients enrolled was Kivexa versus Truvada and efavirenz versus atazanavir, ritonavir. So regardless of the NRTI background, the integrase inhibitors do work, I mean, without difference. That to testify that probably the strength of the integrase inhibitors does compensate for a possible weaker NRTI background, as it is the case here for Kyvexa. Another proof of potency, I was very impressed, the 10-day monotherapy study, dolutegravir, a dose as low as 2 milligrams. Today we use 50 milligrams in clinical ground. So 2 milligrams was able to suppress in 10 days as a sole drug. This was really an unprecedented finding. Concerning the mechanism of action, which is very interesting, so what we learned is that probably the drug integrase inhibitors remain linked to their target longer than expected. So we might envisage a sort of pharmacodynamic half-life, which might be longer than the pharmacokinetic half-life. This might also contribute to explain the superiority in spite of a shorter half-life. And again, to the faster viral load, okay, you get rid of the virus faster, but we also must take into account another property here of integrase inhibitors, is the one of having a good genetic barrier in spite the fact that the number of mutations required to reduce significantly the activity is not so different from NNRTIs, which are known to be drugs with a very low genetic barrier. So what probably the case is that if you get rid faster of the viral load, I mean, as an inference from bacterial infection, I would say that dead bugs do not mutate. So that there is a much shorter exposure of a replicating virus to possible suboptimal concentration of drug. And this clearly, in my opinion, does contribute to the genetic barrier of integrase inhibitors. And that's why you see that it's much lower the rate of drug resistance following virological failure in case of integrase inhibitors as compared to non-NNRTIs. So just to finish some clinical PK update on integrase inhibitors. This was presented by Courtney Fletcher at the CROI, showing the penetration of integrase inhibitors into mononuclear cells taken from the peripheral blood, from lymph node, from ileum and rectum. And you see a less than spectacular penetration of these drugs into these deep sanctuaries, with the exception to some extent of Vitiregravir, and as also suggested by Andrea before, Cobicis that might have so far undisclosed properties allowing a better penetration of drug into deep tissues here. So I think this is if we think that 90% of the virus is probably in lymph nodes or in the reticuloendothelial system, these findings are of some interest in the debate we're going to have tomorrow about 2 versus 3 drugs. If I mean, thinking of the possibility to have a third drug here might be better. There are variables like, you know, the years spent without therapy with a replicating virus, possible lymph node fibrosis with some factors contributing to the lower diffusion of drugs through these sanctuaries. So there's a series of variables. Another point has been discussed by Andrea. I won't stop here, but dolutegravir PK and neuropsychiatric symptoms with the possibility that there's some contribution of pharmacogenetics. And the last features about now also raltegravir is a QD. Now all integrase inhibitors are for a single shot during the day. Has been developed the 1200 QD versus 400 milligram BID. This is not just the same drug given QD. This is another drug. We have 50% of drug more on board here, and if you look at some differences, we might see. You see, this is you look at the left and the right column. That in the middle does not apply here. 600 milligram 2 pills QD, and what we see here that we have a much higher Cmax as expected, because we give, all the treatment is given in a single shot and for 24 hours. The C-trough maybe is a bit lower as expected. However, the chance of getting lower than the EC90 is more or less the same. So does it matter to have such a high Cmax? Okay, however, if you look carefully, all the slides, all the material of this trial, you see that the only signal of difference between the 1200 and 400 milligram BID is in the subset of those starting with more than 500,000 copies. This is, I mean, very small numbers. So this is from our viewpoint, from a clinical viewpoint, is not a trivial finding, because this is an Italian case series. As many as 15% of patients naive had more than 500,000 copies. So having a drug that performs better in this virological strata is good news. The other thing is that when we have such huge viral burden on board, the absolute number of spontaneous mutants to be selected is much higher. This is also an inference from a bacterial infection. So the chance of having mutants prone to be selected by suboptimal use of the drug is much higher. And again, as an inference from bacterial infection, this is the same total daily dosage of ciprofloxacin against Pseudomonas aeruginosa in a hollow fiber system. And if you see here, if you give 400 milligram 3 times daily or 600 milligrams BID, you have a regrowth with resistance. But if you give a single shot of 1200 milligram of ciprofloxacin, you have a bacterial regrowth but no resistance. That's possibly suggesting that, you know, as beta-lactams do in clinical pharmacodynamics, the Cmax might matter in terms of prevention of drug resistance. And thank you for your kind attention.